The most important part of an ultrasound examination is the initial survey scan. The survey scan first allows the sonographer to obtain an overall impression of the organ of interest. The survey scan is the time to be able to quickly, yet comprehensively, evaluate the organ of interest. The survey scan should also identify areas that require more time to examine during the rest of the ultrasound examination. The sonographer should, at the completion of the survey scan, be able to state whether the organ has pathology or not. Oftentimes, when a survey scan is not performed, pathology is missed. Recording the survey scan can also allow others that may not have been present during the live scan to confirm the findings of the sonographer who performed the study. I will present several cases to highlight these principles. The first case is that of a 31-year-old attorney with primary subfertility for the past several years. His past medical history is significant for epididymitis as an adolescent, accompanied by swelling of scrotum. He was treated with antibiotics with resolution. However, he noted a decrease in his ejaculatory volume afterwards. Physical examination suggested a dilated epididymis bilaterally. Low volume, fructose-positive azoospermia was confirmed by semen analysis. Ultrasound was requested due to his azoospermia and history of palpably full epididymis bilaterally. The left testis transverse survey scan demonstrated an enlarged epididymis. Right testis survey scan also demonstrated an enlarged epididymis. The anterior-posterior measurements being approximately 1 centimeter on the right and 0.8 centimeters on the left. Low volume, fructose-positive azoospermia, a transrectal ultrasound was requested. The transverse survey scan demonstrates a dilated right ejaculatory duct which extends into the proximal portion of the seminal vesicle containing a mass. Longitudinal survey scan with color flow Doppler demonstrated that this mass contained blood flow. Several calcific densities, identified by posterior shadowing, were also present. Tissue mass, presumably a polyp, measured 1.7 by 1.6 centimeters. This next case is of a 52-year-old gentleman who presents with erectile dysfunction. A survey scan was done at baseline and after injection of 0.2 mL of our standard dose of trimix as shown here. Although not appreciated at baseline, there appears to be a calcification in the left cavernosal artery. A longitudinal scan of the left cavernosum demonstrates 2 calcifications in the cavernosal artery. As shown here, the survey scan with color Doppler demonstrates that one of the calcifications is at a bifurcation of the cavernosal artery. This next case is of a 42-year-old gentleman who presents with a firm testicular lesion. Evaluation of a scrotal mass is one of the most common indications for scrotal ultrasound. The sonographer's goal is to identify the location of the mass as well as the mass's blood flow relative to normal testicular tissue. An intratesticular mass with increased blood flow is pathognomonic for a testicular tumor. The survey scan demonstrates a hypoechoic mass in the superior anterior portion of the testis. This mass measured 2.8 by 2.0 centimeters. The addition of color flow Doppler demonstrates increased blood flow in the mass, confirming the diagnosis of a testicular tumor. The next case is that of a 33-year-old gentleman with primary subfertility and low volume, fructose-positive azoospermia. A scrotal ultrasound was requested to evaluate the fullness identified posterior and lateral to each testis. A longitudinal survey scan of the left scrotum shows a normal-sized testis with dilated structures posterior and lateral to the left testis. A longitudinal scan of the right hemiscrotum shows similar findings. As shown here, the epididymis was approximately 1 centimeter on the right side and approximately 0.8 centimeters on the left. A transverse survey scan of the prostate demonstrated a small hypoechoic structure just to the left of midline. A longitudinal survey scan of the prostate showed dilation in the region where the ampulla of the vas deferens and seminal vesicles would merge without visualization of the rest of the seminal vesicles. This subfertile patient presented with low-volume, fructose-positive azoospermia. His scrotal ultrasound demonstrated dilated epididymis bilaterally. He had a normal FSH, LH, and testosterone. Genetic testing for karyotype and micro-Y deletion analysis was also done and was normal. The patient elected to undergo a bilateral testis biopsy for diagnosis, sperm retrieval, and cryopreservation, together with a formal microsurgical vasotomy and vasogram, and possible reconstruction. The vasogram, demonstrated here, shows a blind-ending right vas deferens and dilation of an abnormally elongated and convoluted distal left vas deferens. This case is of a 30-year-old male who presented 2 days after left testicular trauma. On examination, he had an enlarged left hemiscrotum that was firm, did not transilluminate well, and was tender to palpation. Scrotal ultrasound demonstrated a moderate hydrocele and a small disruption in the tunica albuginea of the testis. A small portion of testicular tissue was found exuding through the tunica albuginea. There was a hypoechoic region deep to this tunical tear consistent with hematoma. With color flow Doppler ultrasound, good blood flow was visualized except for the tissue extruding through this tunica albuginea and in the region of the testicular hematoma. This case demonstrates the ease and speed of identification of traumatic injury to the testis with the survey scan. There are several key points to take away. The survey scan first allows the sonographer to obtain an overall impression of the organ of interest. The survey scan also allows the sonographer to quickly yet comprehensively evaluate the organ of interest. The survey scan identifies areas that require more time to examine during the rest of the ultrasound examination. The sonographer should, at the completion of the survey scan, be able to state whether the organ has pathology or not. Oftentimes, when a survey scan is not performed, pathology is missed. Recording the survey scan can also allow others that may not have been present during the live scan to confirm the findings of the sonographer who performed the study.